this was the introductory part of the tuberculosis of the spine. Now, as far as clinical features are concerned, it is not very difficult to remember, or there is no such specific clinical features on the basis of which you will identify that the patient is suffering from tuberculosis of the spine. This is some condition which you have to diagnose based on ruling out the other options out. All right. So it is weight loss, fever, anorexia, and these are the constitutional symptoms. But what are the clinical features which remains common in all the conditions of the spine? Like there will be back pain, there will be stiffness, there will be limitation of movement. So it remains common. Nothing specific as far as clinical features of tuberculosis of a spine is concerned. There are several conditions where the clinical features are more or less specific. Like in case of avascular necrosis, head of the fever, there will be limitation of abduction and internal rotation, which is more or less diagnostic for that particular condition. But in this case, tuberculosis of spine, there is no such clinical feature which is almost diagnostic. All right. Now, this is something which is important for you to remember practically also, that in case of a young female who comes with a very long history, protracted history of a back pain, which was subsiding initially with the administration of the painkillers, but now it is refractory to those painkillers and the patient is relatively thin, there is anorexia, there is weight loss, persistent weight loss. Now, in those cases, you have to keep your primary differential diagnosis as tuberculosis of the spine, and you have to rule it out as early as possible or as soon as possible. All right. So, in young female given history of persistent back pain which is not responding to the relaxations should be evaluated for Pott's spine by relevant investigations. So, despite the fact that X-rays are found to be absolutely normal, even in those cases, there is always a possibility that there could be a hidden infection, there could be a hidden abscess, which will be ruled out once you get the proper imaging of that region by MRI. All right. So, this is something which is very important practically also. So, these are the clinical features. As I told you, the symptoms of the patient are not confirmatory for making the diagnosis of the Pott's spine. So, what you have to do next? Next, you have to elicit based on the signs that whether the patient is lying under the category of compression of the vertebrae or not, or compression of the spinal cord or not. That means neurological involvement because of Pott's spine. First of all, why there has to be a neurological involvement, or how can there be a neurological involvement by this Pott's spine? Just try to understand. Imagine this is the vertebrae, and posterior to the vertebral column we are having the spinal cord. Now, if there is a collection of the abscess because of the destruction, there is a collection of the abscess. This abscess as well as the inflammatory or the destructive tissue can lead to a compression of the spinal cord. It can lead to a compression of the spinal cord. Once the spinal cord gets compressed, there will be a evidence of the neurological deficit. And that neurological deficit will be elicited once you perform the testings on a patient who might be suffering from tuberculosis of the spine. So, these neurological deficits are graded into 4 different grades. The first grade is that the patient is able to walk. That means the patient is not feeling any sort of motor weakness without support. He manages to walk without support. But when you examine the patient by performing the deep tendon reflexes, when you perform the plantar reflex, then the features of upper motor neuron type of the paralysis, that means the compressive features, they become evident. So, patient is not aware of any neurological feature. You are going to make them elicit by performing these tests. Now, patient manages to walk without support, not aware of the neurological involvement. Plantar will be found to be extensor, exaggerated deep tendon reflexes, and no sensory involvement. That is grade 1. Now, in grade 2, but if there is a lumbar involvement, then the grades of the paraplegia or the grades of the neurological deficits are slightly going to be different. Now, in case where there is only quada equina, all right, where there could be a compression of the nerves only, then in those cases, all these grades of the paraplegia could not be affected. It is for the involvement of the spinal cord because of the tuberculosis of the spine. That is the reason why when we are going to talk about the management, we will be categorizing the patient into 2. Either they are neurologically affected or they are neurologically non-affected. Now, that was grade 1. Now, in grade 2, what will happen? That over a period of time, the patient will feel the progressive weakness. So, the patient manages to walk, but he used to walk with support. So, The patient walks with support, aware of the weakness. The plantar extensor, it remains the same. Exaggerated deep tendon reflexes, it remains the same. Increased tone of the muscles, it remains the same. But there will be a beginning of the sensory loss. All right. The patient would be able to feel that if you ask him that, you know, I'm touching the forearm of yours and I'm also touching the thigh of yours. Is there a difference in between the sensations based upon the level of involvement? Is there any difference in the sensations? So he will say, yes, means the touch on the lower limb is 20% lesser, is 10% lesser, is 25 or 30% lesser. Likewise, the patient would be able to feel that I'm having lesser sensory intact sensations as compared to that of the upper limb. All right. So based on the level involved, you will test the sensations for. Next, with the progression of this neurological deficit, now comes the stage where the patient won't be able to walk. Means even with support, the patient cannot walk. So it is inability to walk. Sensory loss is going to be more than 50%. So these are the 3 grades of involvement of the vertebrae, involvement of the neurological system by this sports spine. And finally, it might culminate into grade 4. Now, in grade 4, what happens? If any of these are present, then it is considered to be grade 4. Like, if there are features of lower motor neuron type of the palsy, like there will be loss of DTRs, there will be loss of plantar reflex, there will be loss of tone, there will be flaccidity of the lower limbs. Apart from this, if there is a bowel or bladder incontinence, that means there will be defecation, there will be urination, the patient is not able to control it or the patient is not able to feel it. All right. So in incontinence of the bowel and or bladder, and the patient obviously is not going to walk because there will be a power of either 1 or less than 1 by 5 in the motor muscles. So there will be paraplegia inflection, more than 50% of the sensory loss, bowel or bladder incontinence, and if there is lower motor neuron type of the palsy, like there will be loss of DTR, loss of deep tendon reflexes, there will be no tone or the loss of tone of the muscles, and there will be no plantar response. Now, in these kind of the conditions, the patient is subjected to the patient is categorized as grade 4 paraplegia or grade 4 neurological involvement because of tuberculosis of the spine. All right. So hopefully everything is clear related to these different grades. Now, these grades are helpful in not only in making the diagnosis, but also to talk about the prognosis. Means it will also dictate the prognosis of the patient and it will also dictate the management guidelines. All right. So these grades are helpful in making the diagnosis, in depicting the prognosis, and in the management protocols. Now, before we talk about the treatment, it is important to have a discussion on that how the X-rays are going to occur or how the X-rays will be appearing in case of tuberculosis of the spine. Now, as far as earliest finding of the X-rays are concerned, which obviously is not going to lead to the diagnostic pattern, will be a loss of normal curvatures of the spine. Because of paraspinal muscle spasm, there will be a lordotic loss, there will be a kyphotic loss, which is normally present in the lateral vertebral visualizations. Just imagine if there is a paravertebral spinal spasm, then it will lead to the contraction of all the muscles, and this contraction of the muscles will lead to a straightening of the vertebral body on the lateral view. So there will be a loss of normal curvatures of the vertebrae. That is the first X-ray finding, that is the earliest X-ray finding. But you know, this X-ray finding will happen even in case of trauma. It can happen in PIVDs also, that means prolapse intervertebral disc space. It can happen in case of degenerative disc disease also. So there are any condition which is affecting the vertebral column, the first thing which will happen is the paraspinal muscle spasm. So this X-ray finding could be the earliest, but it is not dictatory X-ray finding for the tuberculosis of the spine. Now, the first X-ray finding on the basis of which you will think that possibly it is because of the tuberculosis is the reduction of the joint space. You know, paradiscal type of the tuberculosis is the most common type of TB. And what happens if the two vertebrae, in between the two vertebrae, the intervertebral disc is eaten away by the organism, it is destructed by the organism, then the adjacent vertebral plates are destructed, as a result of which the disc space in between the two will be diminished. This is known as reduction in the disc space or reduction in the joint space in between the two. All right. So this is considered to be the earliest X-ray finding, which will helpful or which is helpful in making the diagnosis for tuberculosis of the spine. Next is crowding of ribs. Now, what do you mean by the term crowding of ribs? It is not difficult to understand that in case of thoracic vertebrae, if there is an involvement of the thoracic vertebrae by the sports spine, then what will happen? If these are the vertebrae, and for example, the tuberculosis is present in between 3 and 4 because there will be a reduction in the disc space. Now, attached to the transverse processes are the ribs. Now, as you can see, the distance in between, the normal distance in between the two ribs is this much. But the distance in between the two ribs which are attached to the vertebrae, which are affected by the tuberculosis, will be reduced. And the two discs or the two ribs are found to be crowded. So, it will be a helpful X-ray finding in achieving the diagnosis. It will be a suggestive X-ray finding for achieving the diagnosis. So, this is crowding of rib phenomena. And then finally, the bird nest appearance. Now, what will happen as a bird nest appearance? Just try to understand. If there is the formation of the abscess because of this tuberculosis, then this abscess will be having the maximum diameter at the site which is affected. So, this will be having a maximum diameter. Then if you move proximally, there will be a tapering, and if you move distally, there will be a tapering. So, there will be a tapering when you move proximally and distally, giving it an appearance of a bird nest. Alright, so this is what the bird nest appearance is. So, that is the another X-ray finding, that is out of crowding of ribs and the bird nest appearance. There is also a fifth X-ray finding, and that fifth X-ray finding is actually the late X-ray finding, which is going to be considered to be a terminal event in the tuberculosis of the spine, and that is angular kyphosis. You know why there will be an angular kyphosis? Just try to understand. Imagine if this is a vertebrae, or these are the vertebral bodies, and there will be a tuberculosis of the spine in between the two vertebrae, then over a period of time what will happen? These two vertebrae will be fused against each other, and because of this fusion, there will be a continuous posterior angular deformity that will appear. The continuous posterior or persistent posterior angular deformity, that will be a progressive kind of the deformity. So, this posterior angulation will lead to a formation of the kyphotic angle. So, this is a late X-ray finding in tuberculosis of the spine, that is angular kyphotic deformity, because normally thoracic spine is kyphotic, but it is not an angular, clear-cut angular deformity. It is the normal kyphosis is usually a globular kind of the kyphosis. Alright, it is not angular. But in case of tuberculosis of spine, because of destruction of the two vertebrae, there will be a posterior angulation, which will be a sharp angulation, and that is known as angular deformity, which is a late X-ray finding. It's a late X-ray finding for tuberculosis of the spine. So, quickly, let's have a discussion on what we have discussed in the X-rays finding or the X-ray appearances for tuberculosis of the spine. The first X-ray finding is loss of normal curvatures of the spine, which is because of the paraspinal muscle spasm, which obviously will happen in all the conditions of the spine. So, it is not suggestive of tuberculosis, but it is simply the earliest X-ray finding. Alright, reduction in disc space is something which will suggest you that possibly the patient is suffering from tuberculosis of the spine. Then, crowding of rib phenomena, we just now came to know. Bird nest appearance, where there is a fusiform abscess formation which is having the maximum diameter. It will appear as a shadow. It will not appear as an abscess. It will appear as a shadow on the AP view of the X-rays. So, bird nest appearance is also appearing as a fusiform abscess. All of you know what the fusiform swelling is, where there is a central diameter of that particular abnormality is maximum. When you move up, there will be a tapering, and when you move down, there will be a tapering. So, there will be a proximal and distal tapering with a maximum diameter at the center. So, this is fusiform abscess and angular kyphosis. So, these are the X-ray findings combined. Now, as far as the management of this tuberculosis is concerned,